What are you concerned about when you think about debriefing and providing feedback?
Most people are concerned about a negative reaction. So regardless of how you present it, you could sometimes expect that.
A negative reaction is the most common thing we fear, isn't it? So I think that you have to do what Jerry talked about. I'm trying to help you to be the best possible nurse you can be. You've told me early on that you don't want to be mediocre, and this is a process by which you can improve. So here's the feedback, and then give the feedback in that manner, right? And if you lay the foundation, as she does in her course, that they know how to give and receive feedback, then they're more likely to hear it instead of being criticized. We all want to be perfect. We're disappointed when we're not. That's no different than you. When you get feedback from students, we all want to be perfect, but we will never be perfect, and the only way to get better is to get feedback and refine, and get feedback and refine. I tell our students that they will always get feedback from this point forward, that they are always being watched, either by their clinical instructor, their clinical manager, their patient, and or their patient family. So get used to it, and be able to listen to the feedback and incorporate it. Amy?
So I'm going to cheat because I'm a simulation educator, so some of this is, I just want to put that disclaimer out there. But one of the things that I will say as far as using standardized patients, my students care more about what their patient thought than about what I thought of them. And often after simulation experiences, if you ask them how they thought it went and what they experienced about it, most of the time they address most of the concerns or the things that you want to address. You have to lead them a little bit more as far as really intentional thinking and really building some of that creative, critical thinking abilities, or where they could have built a better therapeutic relationship or whatever it may be. But for the most part, they're pretty sensitive, and if you allow them to speak it, it's a little less of a sting, I guess.
That's right, than you telling them, yeah. Then the last question, when you note behaviors outside of best practice and prepare to give feedback, what's challenging for you about that? The point I want to make with this is that you are the expert.
Right here. Carol.
Yes, go ahead.
I don't want to undermine confidence either.
Right.
I've been teaching neonatal resuscitation for a number of decades, and we started doing simulations and debriefing several editions ago. And it's really been a learning curve. It's hard. I always like to make the point that no resuscitation is perfect, and in real life, and what went well, and then what could we have done better, and how they could have helped each other. Okay, I'm very big in letting the team coach each other. And did anybody notice anything that that could have been improved? You know, that they might have mentioned to one of their colleagues. I've really started to recently implement a coaching role within neonatal resuscitation in real life for the person who's recording and kind of holding the algorithm, has the cheat sheet there to coach the team.
That's right.
And the other thing that I was going to say about it is that I forgot.
Well, I just want to say that you're not a plant. She's feeding right into what needs to happen next, but that's exactly what needs to happen. I'm coming to see what your name tag is.
Razy?
Razy. So thank you very much, Razy, because that is exactly what needs to happen. Let it be learner-centered. So let's look at this piece. Criteria for effective debriefing.
I'm sorry, can I
Okay, you remember?
what it was. Very often I'll hear, well, if it was in real life, I would have done such and such. They're still having a hard time suspending the disbelief.
Right.
And I'll say, I know that if you were all there, you would have jumped in and started doing tactile stimulation and everything. But right here in our simulation, a lot of people were standing back and waiting for somebody else to do it. And that's my observation, to help them next time with the simulation or real life.
The evidence is if we stand back in simulation, we stand back in practice. So what we practice is what we do. So we have to be careful about that. And so I think the point that I think is really interesting is my husband in his retirement has become a standardized patient. Now I get to see it from the other side of the point. And the thing that I think is really interesting, he had a student come in and said, I don't really get into this. I don't really like doing it. And besides, if you were a real patient, that would matter. And he looked at him and said, I am your real patient. I mean, maybe not today, but I will be your real patient, right? And so I am your real patient. These are our real stories of what needs to happen. And Axel has standards of best practice for simulation. And the resource for them is in the back of your thing, but you need to go there if you're about simulation and follow those guidelines. There's one on debriefing. And these are the components that are in that. But the other thing I wanted to do is just to walk to you that what you're about is enhancing the performance. And there are many different types of debriefing. One is plus delta, one is gas and DML and pearls and debriefing with good judgment. I've touched on each one of these in your slide deck that you can read, but I'm going to jump to the one that I use most often. So you can also read the articles that are referenced in the back, but the point is I like this model. So if someone says to you what kind of debriefing model you use, it used to be okay to say, I kind of use a variety of ones. Well, now it's not okay. You need to really learn one, practice one, and refine one. So make a choice and use it. And you may use some pieces of plus delta and then move into a model, but you need to get used to one. This is the one I was trained in at Cambridge. The Harvard group does this one about debriefing with good judgment. And the idea is that we really look at where the students is coming from, and you look at this idea of approaching it from a point of curiosity or inquiry. So you might say to Carol, I noticed that you were hesitant to call the doctor. Can you tell me a little bit about what you were thinking? So now Carol might say to you, I've heard he's really jumps on people when they call him at home, and I was worried doing that, and I was trying to decide, was this really that important? And you can then move from there and continue the conversation. So faculty know the answer, and so there's several different ways that we can talk about this. They talk about, there's 3 ways that she does this. She talks, Jenny Rudolph, she talks about judgmental debriefing, and we probably all have done this. It is the one that faculty know the answer, and what they want the student to come up with that answer, and the faculty is right and the student is wrong. So the job of the faculty is to set the person straight. That's judgmental debriefing. Anybody, you don't have to raise your hand. Ever done that? We all have somewhere along the line done that. So faculty must also examine our own frames. Then a non-judgmental approach, I've done this too, where we will sugarcoat it. We will say, oh, you did this really great. Well, you can work on this, the sandwich approach. And then you did this really great. So the student leaves and they go, was I good or not? What do I need to improve on? So that sandwich approach doesn't do much for the learner either. That non-judgmental, where we don't want to hurt their feelings. We want to really, we don't want them to cry. And so this is what we might do. So some people call this the sandwich approach. This is what they advocate, that we openly discuss the errors. So we can say, I noticed it took you 7 minutes to put the oxygen on the patient. I'm curious as to what you were doing that delayed the administration of oxygen and what you were thinking. You find a way to respectfully talk about the protocol says that, vancomycin goes in at this point. Whatever the standard of care is, you're the expert. I'm curious why you couldn't get it in at that point. Can you tell me a little bit about what was going on? And then they can talk about that. It focuses on the learner to learn what they were thinking, and it makes sense of their frames and their assumptions, and also identifies their knowledge gaps. And the faculty makes a sense of the simulation. So there's several articles that she's written. I've got some in the reference list. So look at those. Here she has done a table that breaks it out so it's more easily understood. The judgmental, which we don't want to do anymore, I, the instructor, will set you straight. The non-judgmental is I, the instructor, will find the kindest way of filling you in on how to do this right. That's not helpful either. And then the good judgmental is I, the instructor, see what you're doing or not doing, and given my point of view, I just don't get it, so I'm curious. What's going on? Or give my view, we should have gotten the baby resuscitated by, fluids on board at this point. And so that seems problematic because it was this point. Can you tell me what I'm missing here? And then they can tell you what they were thinking at that time. So that's an example of the different styles. So debriefing with good judgment really does value your expert opinion. It values the unique perspective of the learner because they may be coming at it from a point that you never considered. And they allows us to make the mistakes that you feel are worthwhile and intelligent, but they are smart and they're trying to get this right. And so they're not trying to do harm, right? They're smart students, they're smart nurses, and they want to do this right. So we make the assumption of that, then we need to figure out what's the problem here. There's also work around debriefing the debriefer. And as you get better at this, you want to implement that in your programs as too, and put yourself risky enough to have someone debrief you about your debriefing style. And this is the work of that. So I have one more story, and this is my story. This is why it matters. This is why, when we talked about earlier, why the acceleration about quality and safety. So, I've been teaching quality and safety for a long time, and I had an infection, I had a PICC line, I had IV antibiotics at home, and then Wednesday before Thanksgiving, they decided they would pull the line. I was so excited, let me tell you. So they pulled the line, and I went through Thanksgiving, and then this is Monday after Thanksgiving. I go back to work because I've been out of work for 3 weeks. You know how faculty are. We got to get back. So I'm sitting in a faculty meeting at 1 o'clock in the afternoon, and I start having rigors, shaking so hard I can hardly sit in the chair. I am surrounded by nurses who are faculty members, who are my friends. What do? I slip out, and I'm going to take myself home. I go by my office, and my colleague who works with me in the lab said, "What's wrong?" I said, "I don't feel good. I'm going home." She said, "Can I take you to the hospital?" Oh, no. We were a block away from the hospital. I'm going to drive home. She said, "Promise me you'll go by the doctor." So I said, "No problem." And she walked me to the car. She was that concerned. So I get to the car. I go by the doctor's office, and they do vital signs, and they can't see anything wrong. And so they send me on. I get out in the parking lot, and I get violently ill. I have projectile vomiting, and I have diarrhea, and I think, okay, now I have to go home. So I go home, and my husband works an hour away. I finally get home. I get somewhat cleaned up, and I am feeling really bad. So I sit down on the couch, home alone, 35 minutes from the hospital, and I don't really know how I got home. So I call my daughter and says, "Come home. I am in trouble. I need you to be here till Dad gets home." And I called Dad, and he was going to come home and take me to the hospital. So it's the Monday after Thanksgiving. So I'm sitting there waiting for them to come, and I have this sense of impending doom. I never had that before. I had taught that. I knew what that meant. And I thought, wow, that's what that feels like. And it washes over from behind is how it felt to me. And I thought something bad is getting ready to happen. So I'm sitting there, and my husband comes home and says, "It's the Monday after Thanksgiving. It's going to be packed in the ED. Why don't we stay home? I'll fix some chicken noodle soup, and we'll go in the morning." And because I had the sense of impending doom, I knew that was the wrong answer. So I said, I didn't tell him, "Something bad's getting ready to happen." I said, "I think I should go to the hospital." I get to the hospital, and there's a bucket load of people there. And so I get put in the waiting room, and I wait, and it's hours that I'm waiting. I'm so thirsty. I could drink anything, but the only thing left in the machine is actually soda, and I couldn't drink that. So I'm waiting, and I think, I'm really in trouble, and I need to get help. So I decided I'm going to accelerate myself in the queue. And I go to the desk, and I said, "I'm having chest pain." I said it a whole lot more convincing than that, but I was lying. And I said, "I think I need to be seen." And so to their credit, they take me back and do an EKG. And there's no changes, and they put me back in the emergency room. So because I was being smart, I missed the vital sign check. This was right after somebody had died in the emergency room. Remember that? They started vital sign checks in the waiting room. I missed the vital sign check. So I finally get back, and so they're doing a research study on infection. They do me. My temperature's high. I can't pee in a cup no matter what. No urinary output. And so I finally get admitted in the middle of the night. And then I'm in a room with someone who's awake, watching TV, and I said I need to be moved. Trying not to pull the faculty trump, right? And so finally in the morning, I get transferred to a private room, and the head nurse comes in and sees me. Her name is Cynthia Johnson. I don't remember Cynthia coming in, but she did. And she come in the room, and she left. And next thing I know, Janice Galloway is at the door, and she's knocking on my door, and she says, "Hi, my name is Janice Galloway. I'm a rapid response nurse, and you're my project this morning." And I knew what that meant. I was like, oh my, a rapid response nurse is at my door? Oh, thank God, a rapid response nurse is at my door. She comes in, my husband is there, my son is there, and some friends are there. And so my blood pressure is in the 70s, and no urinary output, and I have a temperature of 101 something or 2. I have sepsis, right? So she knows that. The hospitalist team comes in, and I teach my students always not to anchor on one diagnosis and to also ask the question, what's the worst it could be? So I hear them, they do boluses. Vancomycin was started, the big guns were started in the emergency room. So they are trying to resuscitate me before they resuscitate me. So they're giving me the fluids and the boluses, and then they're stopping and saying, "Are you okay? Like, are you in heart failure? Okay, no, you're not. Here's the other bolus." So they're giving me the boluses back to back, and I hear the crash cart come up outside. Nobody in that room but me and the healthcare providers know what that looks like. And then I hear them outside talking about dopamine and vasopressors. And I look at my son and my husband and my friends, and I think, this is surreal, right? And so they come back in, and the doctor says to the nurse, not to me, it's not patient-centered care, "Is those IVs working?" And I looked at him and said, "Yes, they are." I have 2 anticubitals working. And he looked at her again and said, "Do you think we should get a central line in before we get busy?" And I said, "I know what get busy means, and do what you need to do. I hope to survive this." And so he's at the foot of the bed, and he looks at me, and I said, "So what are you most worried about?" And the look on his face was priceless, because that is not a question he would get from a patient. And I said, "I teach patient safety, and I want to know, so tell me." And he said, "We're worried about septic shock." I said, "Oh, thank God, me too. At least we're on the same page." So I was like, oh, good. I don't have to get us to the right page. I just did a module 3 months ahead about sepsis. I knew the statistics of survivability. So my son looks at me and says, "Mom, I've been looking on the internet, and I saw that drinking orange juice is really good for infections. I brought you some." And I thought, wow. And I thought, that's great. He said, "Do you want some? My pressure's now in the 60s. And I said, I would love some, because I thought this would be the last conversation I had with him. And I didn't want it to be one that it didn't look like I was trying, right? So I drank a sip of orange juice, and I nibbled on an organic breakfast that was going to be good for me that he had brought me. He brought me half gallon of orange juice. We could serve the whole floor. But anyway, so I do believe by the grace of God it was a miracle. Janice Galloway only worked on Tuesdays and Thursdays. This was a Tuesday morning. I got transferred to a unit, and Janice went with me. And you talk about that whole idea of being transferred and being a patient feeling scared about being left by the people who had taken care of them. It was really frightening to be transferred. I had worked at this hospital the school of nursing next door for so many years. I knew all the nurses. I roll into the intensive care, and one of my graduates was like, "Carol Durham, what are you doing here?" I said, "I think they think I have septic shock." And he said, "Oh, please not." And I said, "I know." But the long and short of it is, I am here, and I am grateful that I'm in the 99.9% group. So my work and your work should be about the 0.1%, that we can move them to the 99.9%. Because the Sorrel King, it does not matter that 99.9% people survive when 0.1 named Josie didn't. To Helen Haskell, it does not matter that everybody else survived but Lewis didn't. And same thing with Sue Sheridan, with Patrick and Cal. So it doesn't matter really if there's one person who dies every year from healthcare preventable errors, or if it's 400,000, it's too many. And we have to do something different, and I think it's upon us to do something different by the way that we educate, the way we teach people to think, and the way they get to have their voice to speak up. We have to help them to recognize patterns and to know when to call for help, and that calling for help is not a sign of weakness, that it's a sign of excellence. If Cindy Johnson had not called for help, I might not have been resuscitated at the right time. If I had stayed home, I would have died, because I would have passed the point of no return with organ failure by the time I got to the morning and got to the hospital and got through the system. So I am grateful to be here, and that's my husband and my dogs. My story is used in the hospital because I believe the story needs to be heard to help other people know when to get help, and also to help us to value speaking up. So if we're teaching as we were taught, then we're preparing students for a healthcare system that no longer exists. We cannot be doing that, right? We can't keep with this number growing and growing and sit back and say, well, we're humans and we make errors. That is not acceptable. So I want you to consider, how will you help your healthcare practitioners stay curious? Are you going to ask them, instead of saying, tell me about your patient, say, what stands out about this patient to you? What are you most worried about for your patient? What else could it be? What actions will you now take and why? So they begin to think that way. So they're not just saying, oh, I can tell you they got congestive heart failure and recite to you the book that they read. No, that's what they need to know, but this is what they need to think. And this is where we need to move them. So the National Council of State Boards of Nursing did a huge study on simulation. It's in your list. And they have decided that you can have up to 50% of your clinical time replaced by simulation, only if you do these things. You make sure your faculty are trained, you use a theory-based debriefing method, you have adequate number of simulation facilities and the equipment to support quality simulations. And AXL brings you what does a quality simulation look like, so that you can actually know that, and those are all free things that you can get to. So there are some patients whom we cannot help, and we know that. We can help them die with dignity, but there are none whom we cannot harm. And we have to stop that madness, don't we? That's my timer. Thank you very much.